Well, hello, everyone. We are going to talk about a little bit of the physiology and pathophysiology associated with acute respiratory failure. I'll be honest with you, you know all of this. So I'm not going to go over the pathophysiology of asthma and COPD and all those other respiratory diseases. I want to talk a little bit more about the underlying concepts. So we'll start with a little bit of an overview, talk about, define acute respiratory failure. What does it mean? Look at different causes, and then do a little review of the physiology underlying the arterial blood gas. I know you've become well versed in analyzing them, but I like to kind of go back and make sure everybody's really clear on why we see these changes and the ideas behind correction compensation. And then if you are interested, I have a short section on VQ mismatches. And this is, again, another topic that sometimes is not that clearly described in physiology courses or even medical courses. And but it does help you understand some cardiovascular complications that occur with acute respiratory failure or severe chronic respiratory disease, and ARDS, acute respiratory distress syndrome, which is what you're going to talk about next week. So let's go ahead and get started. So a quick overview. So acute respiratory failure means we have a patient whose oxygenation of the blood and often ventilation, so air moving in and out, is inadequate. It results in severe hypoxemia, so their oxygen saturations are very low and they are starting to develop hypercapnia, elevated carbon dioxide levels in the blood. Okay, so nothing new. And so again, just, kind of getting back into the swing of this, from a cellular physiological level, you want to be thinking, well, what happens to oxygen levels and carbon dioxide levels in the blood when ventilation or gas exchange is impaired? So again, here's the alveolus. Oxygen usually diffuses into the capillary down that oxygen concentration gradient, and CO2 goes in the other direction. And so this really, if you know this picture here, and you can picture oxygen normally moving into the blood and carbon dioxide moving into the alveolus, most of what we talk about with respiratory diseases and conditions comes down to this level, okay? So if we impair gas exchange, or if we're not getting enough air into the lungs, so we have poor ventilation, then we're going to end up with what we call hypoxemia, low oxygen in the blood, as we were saying. But then we also have to be remembering now that carbon dioxide is not getting out, so the patient becomes hypercapnic, elevated PaCO2s. So the textbook, when we talk about causes of respiratory failure, the textbook describes these, or divides them into what they call hypoxemic respiratory failure and then hypercapnic respiratory failure. Now, I'll be honest with you. In most cases, once these conditions progress, all of these patients have both hypoxemia and hypercapnia. So kind of like the definitions of absolute and relative hypovolemia, I am not such a fan of this hypoxemic versus hypercapnic respiratory failure. We're going to be drawing arterial blood gases on these patients, so we can tell if they are hypoxemic and how hypoxemic they are, and we can also tell how hypercapnic they are. So take these two categories with a grain of salt, but dive in and look at what are the conditions that could lead to the severe hypoxemia and hypercapnia. And remembering that with severe hypoxemia, it means that the cells throughout the body are probably not getting enough oxygen. And then when we talk about the acid-base disturbances, then we'll talk about why that elevated carbon dioxide levels are so bad. Okay. All right. So I like to chunk and organize things, especially causes or risk factors. There are a wide variety of respiratory conditions, some acute, some chronic, that can lead to acute respiratory failure. Acute respiratory distress syndrome usually has another cause that leads to it, and we will talk about the patho of ARDS and common causes of ARDS, some respiratory, some non-respiratory, next week. Pulmonary embolism Big pulmonary embolism can cause severe hypoxemia and hypercapnia, and it can occur really quickly. Pneumonias could be bacterial, severe bacterial, more severe viral pneumonias, COVID, SARS, etc. We always have to be concerned about our patients that inhale toxic gases. Honestly, it's usually smoke inhalation, so it could be a house fire, a car fire. And then, of course, we have our patient who goes into status asthmaticus. We talked about that with anaphylactic shock in a way, because status asthmaticus is very similar to the respiratory changes that we see in anaphylactic shock, so severe bronchoconstriction. There are also, remember, a number of cardiovascular problems that can affect the lungs and gas exchange. So any patient that develops cardiogenic pulmonary edema, that's usually a left ventricular failure case. Okay, could be acute, could be chronic. And then think about your babies who have, your infants who have some kind of, are born with some kind of congenital heart defect. If that heart defect causes left ventricular failure, then you're going to end up with pulmonary edema. And then, but then if we see shunting where the blood is basically skipping the lungs, then that's going to cause severe hypoxemia. Okay, it's not a lung problem, but the blood is not getting oxygenated. All right, so then again, this hypercapnic respiratory failure, you know, they're all going to have hypoxemia, but hypercapnia becomes pretty much absolute. So there's usually carbon dioxide retention in these diseases. So it tends to be, you know, these chronic respiratory diseases, chronic asthma, COPD. And again, remember, COPD is just an umbrella term for two main diseases, emphysema, chronic bronchitis, that are very different from each other. So honestly, patients should not be getting a diagnosis of COPD unless they don't know what it is or they have both, which is very common or possible because smoking, for example, can cause both emphysema and chronic bronchitis. Cystic fibrosis, again, genetic disease causing mucus buildup in the lungs. So really any severe acute or chronic respiratory condition that results in impaired gas exchange or impaired ventilation will start to build up carbon dioxide, but again, of course, results in hypoxemia as well. Don't forget about the neuro problems. So we talked about neuro from a cardiovascular standpoint with neurogenic shock, but now we have to be thinking about oxygenation and breathing as well. So our respiratory centers are in the brainstem and the medulla oblongata. And if there's severe traumatic brain injury that causes increased intracranial pressure, or there's a primary brainstem injury, then it can cause damage to those cardiovascular control, or sorry, respiratory control centers, and that's when people stop breathing on their own. Sometimes people end up with a stroke, not to the cerebrum, but to the brainstem. You can have a stroke anywhere in the nervous system. Don't forget about oversedation or opioid overdose, right? So all those drugs that will decrease respiratory rate and cause respiratory depression, that is medically induced acute respiratory failure. Okay, they're not breathing. And then because the diaphragm is innervated by level C3, C4, C5, pretty much if there's an injury C3, C4 area, you're knocking out that whole phrenic nerve, all the neurons that would go out the phrenic nerve. And so the person's not going to be able to breathe on their own or contract their diaphragm. Okay, so they're patients with the brain injuries, brainstem, stroke, cervical, spinal cord injuries are often going to be on a ventilator. Neuromuscular problems, again, this tends to be a little more chronic: ALS, muscular dystrophy, multiple sclerosis, where the person just can't, you know, they've had muscle atrophy or muscle inhibition of motor activity or motor stimulation to the muscles, and they just can't take in a deep breath. Okay, so they build up CO2 and their oxygen levels go down. Okay, so big picture, you know me, I love big pictures, summaries. How do we package this all together? What's the take-home message? So acute respiratory failure, because remember, acute means pretty sudden, is often the person has some kind of underlying lung disease, and then there's some kind of acute condition that gets layered on top. Let's imagine a patient maybe has ALS, okay, or muscular dystrophy. They're, you know, they kind of have some chronic hypoxemia and hypercapnia, and then they get pneumonia. okay, they get an acute pneumonia. That patient is going to be much more compromised and much more likely to go into a state of severe hypoxemia and hypercapnia, and then we call that acute respiratory failure, okay? There's not a number, we don't say, okay, here they're not in respiratory failure, here they are. It's just if really we cannot maintain those oxygen levels and the CO2 levels start to climb and their risk for getting hypoxic injury in the body, that's when we're getting serious about this, okay? So always be able to think big picture. All right. The other things we'll review, again, looking at ABG analysis. I always find this kind of fun. It says review video there, but we're just going to do it here. I like to kind of go back to the basics in the physiology because I think it, again, just helps you kind of think through doing an ABG analysis rather than just kind of following steps that you have to memorize. So just a reminder, when you get a blood gas result, it has all this stuff on it. And to be honest, nurse practitioners and physicians mostly don't use that either. It can be helpful. They run, potassium levels and sodium and calcium. And if you haven't had labs in a while, it can be helpful to look at. They will do, all sorts of stuff here, usually hematocrit. So again, if you haven't had a CBC recently, you can just look at it and see, is my patient anemic today? But for the most part, these are the things we're going to be looking at. We, of course, are going to need the pH because we're looking at acid-base balance. We want to look at what will really give us information about their ventilatory status. Are they ventilating or, having good gas exchange? That's our PaCO2, the partial pressure of carbon dioxide as a gas in the arterial blood. And then an indirect measure of how the tissue is being oxygenated would be the PaO2, the partial pressure of the oxygen dissolved in the arterial blood. It's just a very small percent, but it has a particular pressure, and it's a little bit more of a more precise measure of what is actually getting out to the tissues, because that's the oxygen that gets actually transported into the tissues. The SaO2, saturation of oxygen, saturation of the hemoglobin with oxygen, and then just remember that when it's a pulse oximetry reading, it's a little less precise, and they call it the SaO2. I did mention the hemoglobin here because you could have a patient who has a good PaO2 but a low hemoglobin, they're anemic. They're still going to have poor oxygenation. So I always take a look when I'm looking at an ABG, I look at that hemoglobin as well. Because if you have a patient who is hypoxemic and anemic, that's two things that are leading potentially to tissue hypoxia. So we have a much more serious problem. And then, I hate this word metabolic, but it's used a lot. In ABG analysis, we usually talk about, metabolic things being non-respiratory. Really with if we can get a sense of, how much metabolic acids and bases exist in the blood at any one time, we don't measure hydrogen ion concentrations, and the reason why is that they're so small that they really they're difficult to measure directly, and so we measure the concentration of hydrogen ions indirectly through the pH. What we can measure very easily is the amount of bicarbonate ion, the HCO3 minus, and bicarb is plentiful, and the lab, analysis can pick it up easily. I won't go into the basic tests in great detail. It really is looking at the difference, but the amount of difference between the acids and the bases, and usually for the most part, when you're just coming up with a regular, ABG interpretation, it doesn't really give us a lot of core information. It may help the medical team with a diagnosis, but for the most part, we don't use it a whole lot. Okay, so again, this is the physiology. This goes back to what we talked about in Patho a long time ago. So big picture, remember that you've got two systems that can get rid of acid. Our bodies do tend to trend towards producing a lot of acids. Think about lactic acid, ketones, gastric acid, hydrochloric acid, right? So even though our pH is a little bit alkaline, we're always producing acid. So we need systems to be able to get rid of acid so that we can stay within our normal pH range. So one of those systems, of course, is the lungs, and the lungs affect blood pH and body pH by either getting rid of, eliminating, or retaining carbon dioxide. And this equation down below, very simple chemistry, just reminds us of why. Why is CO2, how does that affect acid-base balance? Well, CO2 is a neutral gas, so CO2 dissolved in the blood does not affect acid-base. However, carbon dioxide, when it is dissolved in water, such as in the plasma, in the cytoplasm, in the tissue fluid, okay? If it is driven to the right, and that the arrows will go in one direction or the other based on the pH of the blood. And so if we're driving the equation to the right, it means that we need more acid to be produced. The carbon dioxide and water come together, they form carbonic acid, and carbonic acid is an acid, of course. It's a weak acid. It's kind of like comparison to, carbonic acid to vinegar, and then comparing hydrochloric acid to like sulfuric acid. So both carbonic acid and vinegar are pretty weak acids, but it's an acid nonetheless. And then if our body starts to build up too much acid, if the pH becomes too low, then this equation just automatically moves in the other direction, and we dissociate carbonic acid to make carbon dioxide and water, and then with the carbon dioxide gets breathed off, hopefully. Okay. So again, it's just a little bit of that physiology and how it works, just looking at it, from one direction. If the blood pH or plasma pH goes below normal, so below 7.35, there is an automatic stimulation to the respiratory centers in the brainstem that say, let's increase the respiratory rate. And so here it is in a flow chart. Here's our low pH. Here's the stimulation of our increased respiratory rate. So this signal is going to the brainstem. And then that causes the person to blow off more CO2 than they did, a minute ago. Then in the blood, what's happening here is our lower levels of CO2 mean, we'll still combine with water, but we'll have less CO2, and that'll make less carbonic acid. Okay. So we can change the pH of the blood by getting rid of CO2 or doing the opposite and retaining CO2. The thing to keep in mind, so your body's always kind of going back and forth here. The thing to keep in mind is that when we start to either increase or decrease our respiratory rate to compensate for changes in blood pH, it occurs pretty quickly, not within seconds, but 15 minutes to several hours, and we'll start to see changes in the blood pH. The other thing to just remember, again, this is a weak acid, so a lot of CO2 retention will decrease blood pH, make blood more acidic, but again, the carbonic acid is not a very strong acid, so the pH may not change as dramatically as we'll see when we have a change in metabolic acids like hydrogen. Okay. So always be thinking CO2 is acidic when it's dissolved in water, but it's a weak acid. Okay, so back to the kidneys. The kidneys are really our most efficient organ that is going to help us regulate acid-base balance. And they do it so efficiently, so dramatically, so effectively, okay? Not quickly, but once the kidneys get going, they will have a very dramatic effect on blood pH. And so let's just review what happens. This is a little more chemistry here. So this picture here, this is, let's get oriented. This is in the renal tubules. This cell here that's in yellow, this is a renal tubule epithelial cell. And so let's just say it's a cell in the, say, the proximal convoluted tubule. Okay, just happens to be a cell here. This is the peritubular capillaries, and then this is the urine filtrate. So it all starts back, same equation. In the cells, as carbon dioxide starts to build up, because CO2 is a byproduct of metabolism, CO2 combines with water, which is available, and becomes carbonic acid. If the body is becoming too acidic, what the kidneys will do is they will dissociate the carbonic acid into hydrogen ion and bicarb. Hydrogen ion is an acid, very strong. Bicarb is a very strong base. And the hydrogen ion will be actively transported and pumped into the urine filtrate so we can flush away that excess hydrogen ion. Now you might be saying, well, wouldn't that cause burning, right? Hydrogen ion going through the urinary tract. Well, as soon as hydrogen gets into the urine filtrate, it actually gets buffered again. So it might combine with bicarb that's in the urine filtrate to form carbonic acid, might bind with ammonia, or it might bind with phosphate. Okay, so don't worry about burning. It'll get buffered as it goes out into the urine. But the key thing is we are getting rid of, and we're peeing out, we're urinating out a very strong acid. But that's not all. At the same time, we get rid of or secrete a strong acid, we regenerate or retain or reabsorb a very strong base. The term regeneration is often used because, you know, these CO2 molecules were probably bicarb at some point. So we're just we're recycling in essence. And so we are retaining a strong base, and that will then raise the pH of the blood. Okay. So one thing you can kind of see here is that if the kidneys aren't working, so we have a patient with acute kidney injury or acute renal failure, or even more so chronic kidney disease or chronic renal failure, the kidneys shut down, they are not getting rid of acid. That's the big deal. Okay, that's it. And so the pH of the blood will really start to go down fairly quickly. And that can be, of course, very dangerous and drive a patient to need dialysis. But this also helps you understand, you know, the things, compensation correction. How does the body kind of manage other diseases that affect acid-base balance? All right, so let's talk compensation. So if we have a patient who has developed a respiratory acidosis or alkalosis, okay, so some respiratory condition that's making the blood more acidic or more alkaline, the kidneys can help out as long as they're not in failure, okay? And so we call that helping out renal compensation. And what the kidneys can do is they can use that little mechanism that we saw in the previous slide, and they can increase or decrease the secretion, or we sometimes call it excretion of hydrogen ion, and regeneration of bicarb. So I'm just keeping it a little simpler here. Okay, so the kidneys can help. So if a patient has severe COPD and elevated CO2 levels and their blood pH is going down, the kidneys can help out, and they will get rid of hydrogen. They will secrete and excrete hydrogen, thereby bringing the pH of the blood back up, hopefully to normal, possibly. Okay? And we'll see evidence of this compensation on an arterial blood gas if it's occurring. If a patient has what we call a metabolic acidosis or alkalosis, which is a non-respiratory acid-base disturbance, it's possible that the lungs can help. Let's imagine we have a patient in kidney failure and they're starting to develop a metabolic acidosis. The lungs can do something, right? They could get rid of carbon dioxide. It's not going to be that effective because remember that carbonic acid isn't very strong. But they can either, you know, in an acidic condition, they can get rid of more CO2, or in an alkalotic, like a metabolic alkalosis, you can actually start to see the person retain some carbon dioxide. Okay? So we call that compensation. We can see evidence of that. Sometimes you'll hear about correction versus compensation. I give you just a quick example of what correction might look like. So let's say I go and I work out in the gym and I work really hard and I'm, you know, lifting weights and doing all sorts of exercise, and I start to produce some lactic acid, you know, during and then after the workout. My kidneys are going to get rid of that excess acid. It might take some time, might take overnight or longer, but my kidneys will correct. So, you know, if you were to draw an ABG on me after exercise, I might be a little bit acidic. Probably not enough to stimulate respiratory compensation at this point, but the kidneys are going to kick in. They're going to say, okay, great, I'm glad you worked out, but we're really acidic now, so let's get rid of some hydrogen ion and retain some bicarb. So that's really correction. It's, the body just correcting normally. The lungs are working, the kidneys are working, and so they're just correcting the problem. Compensation is when we have a disease state that's causing an acid-base imbalance, and the other system jumps in to help out. Okay, so compensation. There's a lot of different algorithms and way to learn ABG analysis. And so if you have a method, feel free to skip this completely. But again, you know me, I like things to be linear and systematic when possible. And so this is how I approach ABG analysis. The first thing that I always start with is the pH, because I want to know, is the patient acidic or are they alkalotic? That is the starting point. So let's imagine we look at an arterial blood gas and the pH is below 7.35, so they have an acidosis, or an acidemia is probably the more correct term. Acidemia means, low pH in the blood. Okay, so then what I do is I look at, and it doesn't really matter which you do first, I look at the CO2 and then the bicarb, okay? So just kind of come up with a systematic way to look at it. So let's look at the CO2 first. If the patient has an elevated PaCO2, it means that something's going on in the lungs and they're retaining carbon dioxide. There's no other explanation. So because it's a respiratory problem, evidenced by this CO2 retention, we say this is a respiratory cause to the acidosis. So it's a respiratory acidosis. Okay. Now, people can sometimes get a little, misled. They look at the CO2, the patient's acidic. They look at the CO2 and it's low and they think, oh, it's not normal, it's a respiratory acidosis. Okay. Don't do that. Don't jump to conclusions. Work it out. Tell yourself, ask yourself, does a high PaCO2, can that cause acidosis? And the answer is yes. CO2 builds up, it becomes carbonic acid, it makes the blood a little more acidic, respiratory acidosis. Now, the next thing you're going to look at is now the other finding, which is the bicarb. And in this case, if the bicarb is normal within 22 to 28 millimoles per liter, the kidneys aren't doing anything. They're not helping. It may be, and in many cases, it is because the respiratory acidosis is pretty acute. And that's what we see in acute respiratory failure. We look at the bicarb, it's normal. It's just the kidneys haven't had time to kick in and retain hydrogen and get rid of bicarb. Or the opposite, sorry, get rid of hydrogen and retain bicarb. So usually if the bicarb normal and there's no evidence of renal compensation, it's because the respiratory acidosis is pretty acute, remembering that the kidneys can take 24 to 48 hours to really kick in full compensation. If your patient has a chronic respiratory condition and we look at an ABG, chances are the bicarb levels will be high. Remember, we don't measure hydrogen ion concentrations. Bicarb is the inverse. And so in this case here, if the bicarb is high, it means the kidneys are retaining a lot of bicarb, trying to raise the pH of the blood. That is wonderful renal compensation for the respiratory acidosis. Okay. If the kidneys weren't working, then our pH would be much lower than it is. All right, let's look at the other possible acidosis condition. So let's say we look at the ABG and maybe your routine is to always look at the CO2 first. And the CO2 is either normal or low. And you tell yourself, normal CO2 doesn't cause acidosis, and low CO2 doesn't cause acidosis. So what's going on? Well, the next step is look at the bicarb. And chances are, has to be, that the bicarb will be low. And again, remember, low bicarb means high hydrogen ion concentrations. So if the bicarb is low, we know it causes acidosis. It's not anything going on in the lungs, so we call it a metabolic acidosis. And again, metabolic just means non-respiratory. It could be severe lactic acidosis from severe hypoxic injury. It could be ketoacidosis. Could be renal failure, the elevated hydrogen ions. okay? So then, but again, we want to see, let's take it a little further and let's go look at the CO2 levels. It would be very unusual to have a full-blown metabolic acidosis and not see respiratory compensation, as long as the lungs are working, okay? So this is pretty unusual to have the PaCO2 normal and have a full-blown metabolic acidosis, okay? Usually what you'll see is that the PO2 is low. And if you watch the patient, you can see them maybe breathing more rapidly, prolonged expirations. Remember, we call those Kussmaul respirations. And they don't even know they're doing it. But what the body is getting them to do is blow off CO2. And then the CO2 levels start to drop, okay? It will start to correct or compensate and for the pH a little bit, but again, remember, this is not going to be all that effective because there's only so much CO2 you can blow off, and CO2 forming carbonic acid is a weak acid. The alkalotic conditions you are not going to see as often, and one reason is because we often don't bother with an ABG in those cases because, you know, if a patient, for example, let's look at our first condition. Respiratory alkalosis. Low P is caused by low PaCO2. So the pH is high, the CO2 is low because they are already blowing off CO2. So the primary disease is causing hyperventilation. Okay. So we don't call compensation alkalosis, right? So if a patient has an alkalotic pH and their CO2 level is low, chances are if you look at them, they're hyperventilating. So it may be early stages of acute respiratory failure where they're just blowing off a lot of oxygen and maybe at altitude. Yeah, but in the cases, you know, at sea level in Las Cruces, it's usually early onset of some kind of severe respiratory condition. You know, they haven't impaired gas exchange yet, so they're hyperventilating, they're blowing off lots of CO2. The other example is an episode of anxiety, okay? So in that particular case, if somebody is having a panic attack, we are not going to draw an ABG just to see how alkalotic they are. We can see what's going on. We are going to try to get them to slow their breathing down or rebreathe their oxygen, their carbon dioxide. Okay, so usually this is a bit of a moot point because we're not going to draw an ABG, but in an acute situation of acute respiratory alkalosis, bicarb is going to be normal because the renal compensation hasn't kicked in yet. Somebody is chronically hyperventilating, maybe they're on a ventilator and the rate has been too high for too long, you may actually see renal compensation, but again, that's a really rare case. And yeah, and alkalosis is tolerated a little better than acidosis anyway, so we don't get too excited about it. If you look at the ABG and the PaCO2 looks normal or is low, that's not going to cause respiratory alkalosis. Sorry, high. If the PaCO2 is normal or high, it's, you know, generally would cause an acidosis, but our pH is high, so we have an alkalosis. If that bicarb is high, we know that high bicarb absolutely can make the blood more alkaline, and so we call that a metabolic alkalosis. Causes could be protracted vomiting, maybe a patient with chemotherapy, and some other diuresis sometimes can waste hydrogen ions, and it's not that common. And so again, usually when somebody's vomiting a lot, we just, you know, treat the problem as opposed to drawing an ABG to just see what their pH is. So again, you will rarely see this unless we just happen to be getting ABGs on the person for some reason. If the PaCO2 is normal, there's no respiratory compensation, of course. If the PaCO2 is high, then it is possible that the person is retaining carbon dioxide to make their blood more acidic. But it's very limited. This is a very limited compensatory mechanism because there's only so long somebody can hold their breath before they become hypoxemic and have to take a breath. Okay, so you may see a drop in respiratory rate or the respirations become more shallow, but they're not going to stop breathing just to correct their blood pH. There is one last physiological concept that I'd like to talk about. So it's this concept of VQ mismatches. And you can read a physiology book and, you can look at videos on this, but in the end, from a clinical perspective, there's only one VQ mismatch that becomes really helpful and clinically relevant. And that is the explanation that helps us understand why chronic pulmonary diseases like emphysema, chronic bronchitis, chronic hypoxemia, and kind of the more severe chronic respiratory diseases, or the more, the very acute respiratory diseases such as ARDS and SARS that leads to ARDS, why those cause pulmonary hypertension and then right ventricular failure. So I'm going to do a little overview of VQ mismatches, but really from that perspective. We won't look at all the different types of VQ mismatches, just the ones that really help with that explanation. Okay, so what is a VQ mismatch? Well, to understand a VQ mismatch, we need to back up and talk about a ventilation perfusion ratio. So the V is, of course, stands for ventilation, and Q technically stands for perfusion. They didn't use P because P is used for pressure, and the next letter in the alphabet is Q. So normally, we look at this picture here. Here's an alveoli being ventilated with air. Here is a pulmonary capillary being perfused with blood. Normally, the ratio between the volume of air coming in and the volume or rate of blood going through the capillaries is pretty much 1-to-1. Now, it's not technically 1-to-1, and I have a little note here. It can range between 0.8 and 1.2 and is different in different parts of the lungs. But I think in terms of conceptualizing it, if you think that ventilation and perfusion are matching each other, that's a very good understanding or analogy. Okay. So we'll just say, we're always trying to match ventilation to perfusion. And when we do so, then we get good gas exchange. Now, if we alter V or Q, so if ventilation decreases or perfusion decreases, okay, then we're going to affect that ratio, and we get what is called a mismatch. So we may have, more ventilation than there is blood coming to pick up the oxygen, or vice versa, less air getting through, less oxygen, and the same amount of blood. So we're, in a sense, kind of having wasted ventilation. So as I say here in the notes, there's really only 2 scenarios that really result from disease states that we need to worry about. So we could either have decreased V or ventilation, and that's going to occur with any pulmonary disease or problem. It could be asthma, status asthmaticus, emphysema, cystic fibrosis, whatever you want, pneumothorax, pulmonary effusion, keep listing them, okay? Those will all affect the amount of air that's getting in and then across the alveolar capillary membrane. The other possibility is you could have a decrease in Q, and that is generally caused by a pulmonary embolism. So there's really usually only one example of something that would cause a decrease in perfusion. So therefore, if we think normally our VQ ratio is 1, if our ventilation goes down and Q stays the same, then we have a VQ ratio less than 1. If ventilation stays the same, but perfusion goes down, then we have a VQ ratio greater than 1. In the end, they both result in decreased gas exchange. They are both VQ mismatches. Now, that's not the important part, because we know that already. We know if we're not ventilating well, we're not getting good gas exchange. If we're not perfusing the lungs well, we're not getting good gas exchange. So we end up with hypoxemia and hypercapnia. What's important here is to understand that the body does not like to hang out in a state of mismatch. And so, like we've seen so many different times, it compensates to try to bring that VQ ratio back to 1-to-1 so it can kind of optimize gas exchange. Okay. So we're going to look at the most common complication or VQ mismatch. And it occurs, or can be summarized as a VQ ratio less than 1 caused by a low V. And Usually that's caused by an airway obstruction of some sort. So what we have to imagine, and this is a little bit artificial, but imagine that the airways are all open and then boom, they're obstructed, okay? At that point where the airways are obstructed, we have a decrease in ventilation. It could be from bronchoconstriction, it could be a mucus plug, it could be a collapsed lung, could be pulmonary edema, collapsing alveolar ducts and alveoli. Okay, it doesn't really matter. I've kind of conceptualized it with a mucus plug. So our ventilation has become low and Q at this instant is normal. So what we have now is a situation where there is normal perfusion without adequate ventilation. Blood is going by the alveoli, but there's not enough oxygen to pick up. And we're not going to be able to get rid of carbon dioxide. This is our mismatch. This is our VQ ratio less than 1. So the question now is, what could the body do physiologically to bring that VQ ratio back to 1? That's going to be our compensation. Okay. So if you think about it mathematically, if V is low, then we need to make Q low. Okay, we need to bring them back to the same, so it's a 1-to-1 ratio. And that's exactly what happens. So the body will stimulate some mechanisms that will bring decreased perfusion to that obstructed alveoli and then bring that ratio back to normal. So the question is, through what mechanism, what physiological mechanism could the body decrease blood flow to these alveoli? There's really only one mechanism that affects blood flow to the capillaries, and that is vasoconstriction and vasodilation. And so in this case, what's going to happen is these cells, alveolar cells, are going to release a mediator that stimulates vasoconstriction. And that will vasoconstrict the arterioles that feed these capillaries. It will decrease Q. And that will then bring our VQ ratio back to normal, okay? And this occurs all the time when there is low oxygen in the tissues. So now, as we kind of expand that or build that up to a higher level, I want you to think about what could happen if a patient has chronic lung-wide disease, emphysema, chronic bronchitis, cystic fibrosis, or if they have a more sudden acute respiratory problem, SARS, ARDS, COVID, etc., okay, COVID-related pneumonia, where they have severe decreases in ventilation and gas exchange. What we're going to see is we're going to see vasoconstriction in not just selected parts of the lung, but we're going to see vasoconstriction in all the arterioles and maybe even the arteries that are feeding the lung tissue. And so imagine this, all of the branches of the right and left pulmonary artery are vasoconstricting, trying to bring that VQ ratio back to 1. All they do at that point is that they raise blood pressure. And over time, that develops into what we call pulmonary hypertension, elevated pulmonary arterial pressure. And then if you remember from pathophysiology, when those pulmonary artery pressures are really, really high, it overloads the right ventricle and can start to induce right ventricular failure. And so again, kind of an obscure physiological concept, but has a very important clinical relevance. And so I hope at this point, this will help you remember why any severe or chronic hypoxemia will eventually lead to pulmonary hypertension. And then as the nurse, you should be looking for signs of right ventricular failure. All right. And that is all I have for you. I hope that, again, this gives you a little bit of a review and a foundation for all of your assessment findings, laboratory interpretation, and then action plans. What are you going to do as a nurse? What are the interventions that you're going to activate?